all to the 2025 August edition of the monthly seminars of Neuroradiologic Society of Nigeria. And we are happy to have you on the platform for today's webinar. Our resource person for today is Dr. Ilili Amin. And without wasting much time, I want to read her bio and have her take up the presentation. So Dr. Ilili Amin is a dedicated and highly skilled neuroradiologist. She's serving as an assistant professor of radiology at Addis Ababa University's College of Health Sciences and is a consultant at Tico Ambrose Specialized Hospital. She earned both she earned both her MD and specialty diploma in radiology from Addis Ababa University, where she has practiced for over a decade. Dr. Amin further specialized in neuroradiology through a collaborative fellowship program between Addis Ababa University and the Perelman School of Medicine at the University of Pennsylvania. Her advanced training exposed her to cutting-edge neuroimaging technologies and techniques. In addition to her clinical expertise, she is an accomplished educator and academic leader. She has served in several key departmental roles, including postgraduate program director and director of both the research and examination committees. Passionate about patient care and medical education, she's also actively involved in research with several peer-reviewed publications to her credit. Today, she'll be taking us on the topic imaging of pediatric brain tumors. And we are happy to have you here. You have the floor for the next 45 minutes. And please, we can put our questions as they come in the chat box. And after the seminar, after the talk, we can all attend to it. Thank you very much. You have the floor, ma'am.
Thank you for this warm introduction, and I'll be discussing about imaging of pediatric brain tumors. In the next 1 hour or so, I'll be discussing different features of pediatric tumors, brain tumors. I have no disclosure. These are my objectives. After this presentation, we'll be able to describe different pediatric tumor brain classification, the current and the updated one. We'll see different changes in the new or relatively new CNS tumor classification. And also I would list imaging patterns and findings of supratentorial brain tumors, the common ones, and describe tumor-specific imaging findings of posterior fossa tumors. So WHO classification of tumors of CNS has been evolving, and relatively current and acting WHO classification is a 2021 classification, and this classification has introduced relatively few changes, much changes in the nomenclature, and also it uses different reporting approach when compared with the previous classifications. So this WHO classification uses a hybrid taxonomy. Most of the tumors needs molecular classification for reporting, but some rarely or never require this molecular features to classify. And this classification uses a layered reporting approach where there is an integrated diagnosis of histopathological classification, CNS, WHO grade, and molecular information are all layered up and used as one to give one diagnosis and reporting of those brain tumors. Coming to this classification, nomenclature of the classification are based on location, age, and genetic modifiers are the most important findings and demographics that can be used to classify these brain tumors. And there are also anatomic site specifiers. For example, chordoid glioma is very specific to third ventricle. And previously types and previously used words such as entity and variant are replaced by types and subtypes, and also the terminology anaplastic is dropped from current grading system. So grading includes combined histology and molecular features, and previously for grading Roman numerals were used, and now it's replaced by Arabic numerals. And also there are specific terminologies such as NOS, not otherwise specified and not elsewhere classified, for tumors that cannot be fully characterized. And NAC is for tumor that is fully characterized but cannot fit into current classification system. This classification includes vast majority of tumors, including metastasis. There are 12 groups of tumors in this classification. Majority of them underlies in the group gliomas, glioneuronal tumors, and neuronal tumors. And there are, again, choroid plexus tumors, which are classified separately due to specific imaging epithelial characteristics, and others are embryonal tumors are grouped separately, pineal tumors, germ cell tumors, and also tumors of the cellular region. They are all separately grouped, and under this gliomas, glioneuronal tumors, and neuronal tumors, there are subgroups and different classification, and there are 6 groups under these tumors. Adult type and pediatric type diffuse gliomas, circumscribed astrocytic gliomas, glioneuronal and neuronal tumors, and ependymomas are within this type of WHO classifications. So when we see important features of this classification, it mainly relies on molecular features for particularly the gliomas, and also some embryonal tumors such as medulloblastoma, and different molecular workup is required to classify gliomas. And glioblastoma, a term, specifies that it's the only adult type diffuse high-grade glioma without IDH mutation. And similar tumor in pediatric is classified as diffuse pediatric type high-grade glioma, IDH wild type. And there are many newly defined pediatric type diffuse gliomas are there. So when we see, I took this article from RSNA, and there are this classification under pediatric type diffuse low-grade gliomas. There are 4 subtypes, and this article shows different genetic mutations associated with a specific group. And under pediatric type diffuse high-grade glioma, again, 4 subtypes are classified, and each have specific genetic mutations and methylation profile. And these are diffuse midline glioma, H3K27 altered, where there is this alteration in H3K27 gene, and also have specific methylation profile. And the other high-grade gliomas in pediatrics are diffuse hemispheric glioma, H3G34 mutant, and diffuse pediatric type high-grade glioma, H3 wild type, and IDH wild type. And this mimics, and they say, similar to an adult form of glioblastoma. And the other is infant type hemispheric glioma. Coming to our cases, case 1 is a 3 years old, presented with difficulty walking. And we have this sagittal T2, axial T2 image, which shows homogeneous T2 hyperintense lesion centered in the pons. You see the lesion is unexpansile, and it shows engulfing of basilar artery encasement and displacement anteriorly is well seen. And as you can see, the lesion is more of homogeneous and hyperintense on T1. And this is T1 post-contrast, which shows no area of enhancement. And this is a companion case where an 8-year-old child presented with headache and difficulty keeping balance. And again, we have T2 axial and sagittal image where we have this T2 hyperintense lesion centered in the pons, and you see the encasement of basilar artery, and you see the expansile nature of the lesion. But in this case, there are heterogeneous areas where there is T2 hyperintensity, and you can also see that the lesion is more of an exophytic growth, and involvement of the right cerebellar peduncle is seen. You can see the mass effect it has on the fourth ventricular effacement, and tonsillar herniation is seen in this case. And this case, we have T1 and post-contrast sequences, and we see that there are intrinsic T1 shortening regions within the tumor, and also heterogeneous patchy areas of enhancement is seen. And diffusion shows some bright areas on DWI and low ADC signals, which do not correlate with this post-contrast enhancement. So this case shows different phases of diffuse midline glioma, H3K27 altered. And this diffuse midline glioma occurs in majority of them are in young children. And the typical imaging appearance would be a lesion that's centered in the pons, but it can also involve the brainstem, thalamus, or spinal cord. And typically, the lesion is midline, but sometimes it can be off midline. And the imaging appearance, the typical is the one we have seen on the first case, where there is this homogeneous expansile pontine lesion with no area of enhancement and restriction on diffusion and ADC sequences. But they can be heterogeneous, and they can have facilitated diffusion or diffusion restriction. So they can be variable. And typically they displace or encase basilar artery, and differentials in such type of tumors, particularly when it involves pons and brainstem, other brainstem structures, the differentials are other low-grade gliomas, but the low-grade gliomas tend to be more of exophytic and more of heterogeneous. Moving to the next case is a 10-year-old patient with movement disorder. Again, on this case, on this T2 axial image, we have this T2 bright lesion involving the left thalamus. You see it's an expansile lesion, mass effect on ipsilateral ventricle is well visualized. And also, in addition to this thalamic lesion, there are separate lesions involving the subependymal layer of bilateral frontal horns. And also on post-contrast image, the lesion shows a nodular thick rim enhancement. In addition to this thalamic lesion, there is enhancement of ependymal lining, and also this lesion involving the frontal horns shows enhancement, and they're separate on different sequences. Diffusion and ADC shows restricted diffusibility. So looking at thalamic lesion, where it has heterogeneous nodular enhancement, and this enhancement of the ependymal lining and subependymal nodules, and with restricted diffusibility, the consideration would be a high-grade glioma with CSF dissemination. And so thalamic gliomas can either be low-grade, or they can be high-grade diffuse midline glioma type, which is an H3K27 altered. It can be unilateral or bilateral, and they can involve older age, and they have variable imaging appearances. And there are many articles that shows when thalamic glioma is large in older age group, when they are heterogeneous, and those having low ADC are suggestive of diffuse midline glioma, or the H3K27 altered type, as compared to the low-grade thalamic gliomas. So in our case, we have this restricted diffusibility, separate CSF seeding, And this nodular heterogeneous enhancement suggests that it's high grade and presents with CSF seeding. These are to show different types of pediatric high-grade gliomas, and an article from RSNA shows different tumors like diffuse pediatric glioma with H3 and IDH mutant, and also with G32 mutation, and also the infantile type are shown, but in practice I haven't come across to see these cases, maybe due to lack of those molecular workup. So pediatric type low-grade diffuse gliomas, they are, most of them are newly recognized group of tumors, and there are 4 subtypes. They all show diffuse cell growth, but they are less aggressive than pediatric type diffuse high-grade glioma, and they have absent IDH and histone mutations, and they have absent homozygous deletion of CDKN2A. And this particular genetic mutation is associated with poor prognosis, and they say if it is found, it upgrades the glioma into high grade and grade 4. So the pediatric type diffuse low-grade gliomas, they lack IDH mutation, histone H3 mutation, and also deletion of this homozygous CDKN2A. So there are 4 subtypes, and they on imaging they appear as cortical, subcortical tumors with some stalk-like extension into the ventricles, and they have variable imaging appearance. And when we come to circumscribed astrocytic gliomas, there are 6 tumor subtypes. These are pilocytic astrocytoma, high-grade astrocytoma with pyloid features, pleomorphic xanthoastrocytoma, subependymal giant cell astrocytoma, chordoid glioma, and MN1 altered astroblastoma. Case 3 is a 10 years old patient with abnormal body movement, and so we're moving to the chapter of circumscribed astrocytic gliomas. And so this image shows that very well delineated, circumscribed T2 bright and hyper also intense lesion on flare with mass effect on ipsilateral lateral ventricle and subtle surrounding perilesional edema. And the lesion is also homogeneous and hypointense on T1, and post-contrast shows this wall enhancement of the lesion. So diffusion shows T2 washout with no area of restricted diffusibility. So this is a typical case of pilocytic astrocytoma. So pilocytic astrocytomas are most common primary tumor of childhood. They commonly occur in cerebellum in younger kids, and optic pathway also involvement is common. Supratentorial involvement is like more in older kids and also adolescent and young adults. This group of tumors are WHO grade 1. They are NF1 associated, and they have variable imaging appearance, particularly the post-contrast appearance is very variable. They can be mixed cystic and solid type of tumor with enhancing solid component or with enhancing mural nodule. They can sometimes be also solid, but the typical imaging feature is that they have higher ADC values as compared to other gliomas. Moving to case 4 is a 7 years old patient. So all the cases are, this is a histologically proven case of pilocytic astrocytoma. Coming to a 7 years old patient with abnormal body movement. This axial and sagittal T2 shows again relatively well circumscribed lesion involving the left frontal lobe with this cortical involvement and peripheral based tumor with surrounding perilesional edema. You can also see the lesion is bright on flare, and you can see the surrounding perilesional edema. It has mass effect on adjacent ipsilateral ventricle. You can see this midline shift, ankle herniation associated with the lesion. And post-contrast study shows this irregular nodular type of enhancing wall with associated areas of nodularity. Diffusion shows bright signal, and ADC is more of like iso-intense to adjacent brain parenchyma, but there are subtle areas of restricted diffusibility with low signal on ADC, particularly this enhancing wall seems to have low signal on ADC. So whenever we see a peripheral-based well-circumscribed tumors in pediatric age group, which can also involve the overlying leptomeninges, and also sometimes they have this skull scalloping, we should always think of PXA. In this case, what confuses us was this diffusion restriction associated with the lesion. But PXAs can either be grade 2 and grade 3, and grade 3 particularly can have this restricted diffusibility. So this was a case of grade 3 PXA. And pleomorphic xanthoastrocytomas are one of the tumors that are assigned as long-term epilepsy associated tumors. And there is this typical mutation associated with PXA. They are cortical tumors, peripheral based, and commonly involved lobe is a temporal lobe. They present as cyst with enhancing mural nodule, but heterogeneous enhancement and diffusion restriction is seen in grade 3 tumors. As compared to pilocytic astrocytomas, they have lower ADC. And whenever we see meningioma-like tumor in pediatrics with this peripheral based tumor, they can sometimes have a dural tail and overlying skull scalloping. We should think of PXA. Okay, case 5 is a 2 years old, presented with hemiparesis, and we have this lesion on the left occipital lobe, which is very heterogeneous, and we have this mixed cystic solid component, and it's a lobulated lesion, relatively ill-defined borders, and some small amount of perilesional edema is seen. You can see the nature of the lesion. It's bulky, large, has mass effect on the brainstem and cerebellum, and you can see it's also relatively the cystic areas are bright on flare, both on flare and T2. You have we have this iso-intense solid component, and the lesion is also, the solid part is iso-intense on T1. It shows post-contrast enhancement. The solid component shows post-contrast enhancement with enhancing cystic walls is seen. Diffusion and ADC shows restricted diffusibility of the solid component. This is a typical imaging feature for supratentorial ependymomas, and ependymomas, supratentorial ependymomas are not rare, particularly in pediatric patients. In fact, 30% of ependymomas are supratentorial in pediatric age group. And there are 2 molecular groups according to genetic fusions, and they say they have variable imaging appearance. They mostly arise from frontal and parietal lobes, and on imaging, they are bulky, cystic, solid, lobulated lesions with heterogeneous enhancement, and also calcification is a common feature. And there is this sign, a periwinkle sign. They resemble the tumor with this flower, where on non-contrast CT, where we have calcification surrounding a necrotic foci and peripheral-based cysts. So usually they say the cysts are peripherally based and the central solid enhancing component, and calcification is very common. So this is a case of proven case of histologically proven case of supratentorial ependymoma. Next case is a 2-year-old female patient presented with seizure, and the imaging shows this bulky solid tumor involving the right frontoparietal lobe, T2 hyperintense to isointense lesion with significant mass effect, midline sheath defacement of the right lateral ventricle, and you can see this serpentine flow voids within the lesion, and also you can see this intrinsic T1 shortening on pre-contrast T1. And since this is a bulky, large, solid tumor, we expect we would have a marked enhancement on post-contrast study, but despite the thought, this lesion have minimal to no enhancement. You see there are patchy minimal enhancement within the lesion. And on diffusion, you see the lesion is very bright, low signal on ADC. So highly cellular lesion should be thought. And this is one of the embryonal tumors in a young age, 2 years old female, bulky, large, solid tumor, supratentorial with minimal to no enhancement and restricted diffusibility is a typical feature of this ETMR embryonal tumor with multi-layered rosette, which previously called as PNET. And this tumor is rare, and it occurs in under 2 years of age, and unlike many other embryonal tumors where there is male predominance or equal prevalence, this tumor mostly occurs in females, and it's commonly occurs in supratentorial hemispheric brain, and it's a large usually presents as large, well-demarcated solid mass with patchy to no contrast enhancement, but significant mass effect is seen with this tumor, and it has poor prognosis. They say median survival rate is like less than a year. So coming to next chapter of tumor classification, we move into a different type of tumor. So this sagittal T2 shows a well-delineated, hyperintense and homogeneous lesion in suprasellar region with some sellar extension. And as you can see in its lower aspect, we have this isointense tissue, which seems to be separate from the lesion on other sequences as well. And on axial T1, we see it's hypointense and homogeneous, and post-contrast study shows wall enhancement with this lobulated margin. So with this, we'll discuss some imaging features in sellar region tumors. The first thing when we encounter sellar region tumor is to identify the pituitary gland. And particularly T1 sagittal image is very helpful. It would show us T1 bright spot, and if we are able to see the pituitary gland separately, then would know that it's not originating from the gland, so would kind of rule out adenomas. And then once we identify the pituitary gland, sometimes it's difficult, in fact, and we rely on other features to give possible differentials. And then once we identify pituitary gland, we should determine the epicenter of the mass, as see the bulk of the mass, whether it's in the sella or it's coming from the above or below or lateral to the sella. And these are very important because there are many pathologies in this region. So looking at epicenter and coming to where it's located would give us a clue that the origin of the mass would be either meningioma or it could be either macroadenoma or craniopharyngioma. And also it could be a vascular lesion arising from a lateral aspect. And once we determine the epicenter, we should characterize the lesion as whether it's cystic, solid, or mixed cystic solid, and whether it has T1 hyperintensity, which can be seen in viscous fluid or in hemorrhage or in fat-containing lesions, and also see if there is associated calcification, and then come to possible differentials in this case. So this case is a purely cystic lesion in suprasellar region with sellar extension and thick kind of wall enhancement, T1 hypointense. The most likely diagnosis in this case is a craniopharyngioma. So again, this is a proven case of craniopharyngioma. They usually have calcification, particularly the adamantinomatous type, which occurs in pediatric age group. They are cystic solid or cystic lesion with wall enhancement, and calcification is common. Okay, so next case is a 2-year-old male presented with headache and vomiting. This lesion is about localizing. So where is the lesion located? It's very important. There are many structures, possible structures that this tumor can arise from. So localizing the lesion would be very helpful to give, again, possible differential. So we see that there is a lesion which displaces the cerebellum posterior inferiorly, and also there is this tectal plate. It seems to be compressed and displaced anteriorly. This is a third ventricle. So the lesion, also on post-contrast, we can see the internal cerebral veins, which are displaced anterior and superiorly. So we know that the lesion is not from the tentorium, and we know that's not from tectal plate, it's not from cerebellum, it seems to be separate from fourth ventricle and third ventricle. So this is typical of a pineal region mass. And once we know that's a pineal region mass, then we should characterize the lesion as its signal characteristics. This is a mixed solid cystic lesion with hyper intense cystic areas which are suppressed on flare, and we see the degree of obstruction at cerebral aqueduct and associated acute hydrocephalus. And the most important thing in pineal region tumor is to see the calcification, normal pineal calcification, whether it is exploded or engulfed. And in this case, this SWI shows centrally placed area of blooming foci, and which suggests that there is a kind of engulfing of this pineal calcification. This is important, they say, to differentiate pineal parenchymal origin tumors from germ cell tumors. The germ cell tumors, they would explode, they come and engulf the calcification, while the pineal parenchymal tumors, as they originate from pineal glands, they kind of explode the calcification. And the other important imaging sequence in case of pineal region tumors is looking at the diffusion and ADC, particularly germ cell tumors and pineoblastomas. Pineoblastomas in pediatrics would have restricted diffusibility, particularly the pineoblastoma, since it's small round blue cell, it would have restricted diffusibility at very low ADC values. So this is very important, particularly in low resource setting where we don't do stereotactic biopsy, differentiating particularly germinomas and pineoblastomas. Pineoblastoma is very crucial. Unlike other germ cell tumors, germinomas would have normal biochemical markers. So this case, biochemical markers were normal, and a possibility of germinoma suggested, and that this patient underwent radiation. And you see post-radiation, bulk of the lesion is gone, the enhancing solid component is no more visualized, and very responsive to radiotherapy. And this is most likely case of germinomas. And coming to other group in pineal region, particularly pineoblastomas on non-contrast CT, they are this well-circumscribed, solid, homogeneous tumor with peripheral calcification. And most likely pineoblastoma diagnosis was given to this patient, and patient is on follow-up. So pineal region mass tumors are either pineal parenchymal tumors or germ cell tumors, which is most common site for germ cell tumor is a pineal region, and either be glioblastoma, tectal plate origin gliomas, and metastases are also the differentials in this region. When we come to posterior fossa lesions, the most important thing is to localize a lesion, whether it's in the cerebellum or in the brainstem, in the fourth ventricle or in the foraminus or in the CPA. And then the next thing we should do and look at is the ADC on MRI. So low ADC tumors are highly cellular, packed cellular tumors such as medulloblastomas or ATRT if it's in the CPA. So the fourth ventricular lesions with higher ADC or intermediate ADCs are ependymomas, and the brainstem tumors are the gliomas that we have seen in previous slides. And when we don't have CT or MRI, and CT is done primarily, we can also assess the cellular nature of medulloblastomas on non-contrast head CT. So case 9 shows where we have this hyperdense lesion, seems to be in the midline in the vermian region, and also diffusion ADC proves that there is restricted diffusibility. So this was a case of medulloblastoma, and the most important imaging features are diffusion-weighted findings and ADC findings, or hyperdensity on non-contrast CT. Medulloblastomas are most common malignant brain tumors. They say it arises previously from the roof of fourth ventricle in superior medullary velum, but there are different molecular subtypes, and so there are variable occurrences and site of involvement in this different type of medulloblastomas. As opposed to previous thought of origin, which is a roof of fourth ventricle. And these are highly cellular tumor, and they have this rapid clinical onset. CSF seeding is common. So post-contrast study of entire neuroaxis should be recommended in these patients. And extra CNS metastasis is also common. So metastatic workup should be also included in the workup of the patients. There are subgroups, WNT, SHH activated, and also non-WNT and non-SHH activated medulloblastomas, and also group 3, group 4 subtypes are there. And so according to current classification, age at presentation is also variable depending on each subgroups, and they have variable imaging appearance as well. But the underlying and important feature of medulloblastoma, they are densely packed small round blue cells, which means on imaging we can either see hyperdensity on non-contrast CT or diffusion restriction on MRI imaging. Case 10 is a 2-year-old child with multiple cranial nerve palsy. What we have is this heterogeneous tumor. T2 axial image shows heterogeneous lesion on the left CPA with extension into Meckel's cave, and also medial portion of anterior cranial fossa, skull base involvement, and post-contrast study shows the heterogeneous and avid enhancement of the lesion. And SWI shows this prominent area of blooming. Diffusion and ADC shows restricted diffusibility. So again, young patient, CPA angle tumor, highly cellular with restricted diffusibility, and heterogeneous post-contrast enhancement should suggest the possibility of embryonal tumor, and most likely an ATRT, and this was a case of ATRT. And the imaging differentials would be medulloblastomas, but medulloblastomas are usually not that heterogeneous, and they commonly involve the cerebellum and also the cerebellar peduncle rather than CTA angle lesions. Case 11 again shows typical imaging appearance of one of the tumors that we have discussed on our previous slides, but it seems to be more of somewhat a typical location. So this T2 axial shows this T2 bright lesion on the involving the vermis adjacent to the fourth ventricle. The question here was, is it a ventricular tumor or is it from the cerebellar hemisphere? It seems to be more of a vermian origin. You see effacement of fourth ventricle, so it's more of in the vermis, and it's T2 bright lesion. And post-contrast study shows this solid enhancing large solid component, and I don't know if it's possible from there, but also this cystic component with wall enhancement. And diffusion, ADC shows facilitated diffusion. So this is typical for cerebellar pilocytic astrocytoma, this facilitated diffusion, T2 bright lesion, and they have variable post-contrast imaging feature. Case 12 is a 6 years old child with difficulty keeping balance. And what we have is on this axial T2 and sagittal T2 is this heterogeneous lesion, I can say, which fills the fourth ventricle. So, and you can see the plastic nature of the lesion where it extends through the foraminus, through fourth ventricular outlet. And you can see the superior extension and also extension through Majendi, and also foramina flushka is involved, and the lesion extends through ventricular outlets. And T1 pre-contrast shows intrinsic T1 shortening, and post-contrast shows more of heterogeneous and somewhat T-qual enhancement. Diffusion and ADC shows areas of bright regions on DWI and low signal, but does not correspond to enhancing post-contrast regions. And these are suggestive of more of a hemorrhage within the lesion. So this is typical case for posterior fossa ependymomas. There are two types, type A and type B. Type A, they say it arises from the roof or lateral portion of the fourth ventricle. Type B, they arise from fourth ventricular floor. On imaging, they are heterogeneous tumors with calcification and cystic areas, and they are known to have this extension through ventricular outlets. Okay, so coming to our last case is an 8 years old with lower extremity weakness. I displayed just a post-contrast study, a brain study on coronal post-contrast study. What we see is this well-delineated lesion with this enhancing mural nodule and non-enhancing cyst wall. And there is a separate nodular enhancing area as well. And with this multiple, this nodular enhancing and enhancing mural nodule, we recommended a spine MRI for this patient, and the spine MRI shows this lesion, intramedullary lesion, expansile T2 isointense with prominent flow voids, and which shows a vivid post-contrast enhancement, and you see surrounding prominent vasculatures and also flow voids within the lesion. And typically, this lesion have this extensive serrings and chordedema. So this is typical case of multiple hemangioblastomas, and this was a case of VHL. With this, I will leave you with a wide range of tumors in pacomatosis, one of the, neurocutaneous syndromes, and So this would be my last slide. So in general, what's the role of imaging in resource-limited setting? It clearly differentiates tumors from tumor mimics, and we can give detailed anatomic presentation and anatomic description, and also complications associated with the tumor. For now, in our setup and most resource-limited setting, we rely on histology classification. Even though for gliomas, giving specific differential would be difficult, but for most of the tumors, we can predict somewhat the grade, looking at the ADC and also the site of involvement and the enhancement pattern. But, you know, we hope that molecular workup would be possible and would include those classification in our description. But for now, we rely on histology and giving some prediction based on the location, the age, enhancement, and the ADC values. And the new updates would be in 2000 update of CNS tumor classification. WHO CNS tumor classification would be available soon. We expect it in 2026. So for now, we rely on what we have. Thank you.
Thank you very much. Thank you for this engaging and very informative lecture. We are grateful for that. Thank you so much. Thank you very much. I think it's time for questions. So participants, if you have questions, you can drop them on the chat box, or you can raise your hand, and then you can raise your virtual hand, and I'll call you to ask your question or any comments relating to the lecture. Questions and comments. Okay. Okay. Many people are appreciating you on the chat box. There's a question by Tomitope Bello from Gambia. Do MRI spectroscopy have a role in differentiating virulence of tumors? Thank you for that question.
A role in differentiating the grade of the tumor. I didn't present in our case because usually it's not done, but in some cases where we're in dilemma, where we are not able to grade a tumor based on a conventional MRI imaging patterns, we do, and the Colin peak would definitely tell us that the tumor is highly cellular and higher grade.
Okay, thank you very much. So MRI spectroscopy is important if there are areas of confusions or complications. Thank you so much. Any more questions? Questions? Okay, somebody is asking, how does distribution of tumor histologies, e.g. medulloblastoma, glioma, ependymoma, craniopharyngioma, how do they vary by region, ethnicity, and age in Africa? This question is from Professor Obule.
I haven't seen like a study which involves, up to my knowledge, that studies this different type of brain tumor groups. Like depending on different age, it's common to see like a variable tumors. I haven't seen like a study. This is one, it should be one of the area that we Africans should focus and study the demographics, but I haven't seen a large study that included and studied this pattern of the brain tumors. In our setup, we see a lot of diffuse midline glioma on our MDTs, Black Line Hospital or College of Health Science in Addis Ababa University is one of the setup where we have this patients from across the country. It's the only center where radiotherapy is given. So patients come to our setup and our MDT. We get to see many cases of diffuse midline gliomas, as well as medulloblastomas, ependymomas. So it's difficult to say that this tumor is common, and that's not.
Thank you, Dr. Aliye. Thank you so much for for your comments and for your contributions. I agree with you that these are the areas of challenges, and that's one of the challenges we face in Africa. Just like you have in Ethiopia, we also have just challenges in Nigeria, where we do not have databases or collection, or we can give like prevalence or incidence of some of these tumors, because most of these studies are not properly recorded, and they're done mostly in private settings in our, so it would be good to see if we can begin in our different settings to begin to even hospital settings to collect data and see how these tumors vary and how they, in amongst children, and how their presentations affect, or correspond with global trends. But thank you so much for your insights. Thank you so much.
Thank you, Professor Godwin. Yeah, this is, I think, one of the areas we should collaborate and do a large studies on this area. Thank you.
Thank you, Prof, for that very important contribution. We have another question from Charles Conte. Can you please comment on T2 flare mismatch?
Yeah, so I haven't included on my slides because it's mostly seen in adult patients where we have this low-grade astrocytoma, and it's highly specific sign where we have this T2 bright lesion, which is suppressed on flare centrally, and the flare would be bright. And it tells us that the glioma is diffuse astrocytoma, IDH mutant type. And it helps us to differentiate from another IDH mutant glioma, which is an oligodendroglioma, which have this one P19 codeletion. And it's a very specific sign and relatively sensitive. They say sensitivity is around 80%. Yeah, so I didn't include it because it's mostly seen in adult patients with this low-grade diffuse astrocytoma.
Okay, thank you very much. Thank you very much. Thank you, participants, for the questions, and our resource person for the responses. Any other question or contribution and comments? Okay, in the absence of any other question or comments, we want to appreciate Dr. Ilili for this opportunity and her time and very informative lecture. We also want to appreciate everyone that has participated in this month's seminar. We invite you for that of September and in subsequent months. Thank you very much, and enjoy the rest of your day.